Greetings. On behalf of the American Heart Association, the Texas Department of State Health Services, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Prevention Partnership, welcome to the second session of the 2020 Hypertension Control Summit Series. We are thrilled with the engagement and attendance at the first session in August. It is just exciting to see the momentum of this statewide effort continue. Growing and even in this world of virtual connections. This morning we hope that all of our friends and neighbors, particularly along the Texas Gulf Coast, have remained safe and dry through Tropical Storm Beta. For those of you who are joining for the first time, my name is Allison Smith and I will serve as your MC today. It's my pleasure to guide you through an agenda of learning and sharing, really leveraging the power of self-measured blood pressure and accurate blood pressure measurement. In my role as Program Director for Target BP, I have had the privilege of working with the American Heart Association and the American Medical Association teams toward our shared goal of improving hypertension control. I want to thank you for being here today and for your continuing efforts as we work toward that same goal of achieving greater than 70% hypertension control across the state. Each of you plays a major role in that pursuit, one patient at a time. As we start this session, I also want to thank all of you for participating in the 2020 Target BP Recognition Program, who submitted data on behalf of your organization to reflect their progress toward the statewide goal of hypertension control. We have had more than 200 clinics submit data this year, more than doubling the number of clinics and sites who submitted data last year, which is an amazing accomplishment. I want to share the agenda overview with you today. On the next slide, we have a few notes about what to expect today beyond our welcome accuracy in the context of the challenges of delivering care in COVID. We have a panel discussion and then a call and a very important call to action. I have a few housekeeping items that I just want to mention before we dive in. I want to thank those of you who attended last time and completed the evaluation afterwards following the August session on SMBP. This feedback was really very helpful as we planned this session and as we plan the subsequent session. So I really would encourage you to fill out the evaluation. For those of you who'd like to go back and listen to the session again, they'll be posted on the website. Last session is already posted and this one will be as well, so you can see the slides and hear the content again. For today's summit, everyone except for the speakers will be muted to manage the background noise. I also want to mention that during the presentation, you'll see the speakers and their slides side by side, just as you hopefully are seeing today in the speaker view with me. There's a boundary line between the video of the speaker and the slides that you can slide back and forth, and it allows you to adjust that distribution to your preference. There's some additional comments, I think, in the chat that will help you with those details, if that, with those technical details. We really welcome you to engage via the chat function throughout the event. And just to start with, we encourage you to go into the chat function, the button at the bottom of your screen, and introduce yourself with your name, your organization, and in the spirit of today's topic, we'd ask you to describe how often your organization provides competency training and testing on blood pressure measurement to your healthcare team. So I'd encourage you to go ahead and do that at this point. As our agenda unfolds, we really invite you to share comments or ask questions for the speakers using the chat function. Our team will be monitoring that and they'll respond to some questions real time in the chat, and time permitting, we will address as many additional questions in the Q&A portion of our agenda. Again, this webinar is being recorded and it will be posted on the Texas Hypertension Control Series webpage and emailed out to participants following the event. So to start out today, we'll focus on the importance of accurate blood pressure measurement, addressing the science and practice. They're foundational to blood pressure diagnosis and management. And as leaders and decision makers in your organization, I encourage you to reflect on the leadership role you can play in ensuring that your team has accurate blood pressure measurement equipment, receives routine training and education in blood pressure measurement, and are supported by standardized clinic procedures for blood pressure measurement. I want to introduce today's two experts from the American Medical Association, Dr. Kate Curley and Nurse Linda Murakami. They're going to provide an overview of the science and practice supporting accurate blood pressure measurement, and we'll highlight some of the new resources, new since last year when we met, that will help support your efforts. Dr. Kate Curley is the Director of Chronic Disease Prevention in the Improving Health Outcomes group at the American Medical Association. She serves as the clinical lead on AMA's chronic disease prevention initiatives, including the use of digital health solutions and efforts to improve medical education. Prior to joining the AMA, Dr. Curley served as a practicing family physician and a health services researcher at North Shore University Health System and a clinical assistant professor in the Department of Family Medicine at the University of Chicago. Joining her is Linda Murakami, Senior Program Manager for Quality Improvement in the Department of Improving Health Outcomes at the AMA. As a registered nurse, Linda provides leadership and technical expertise to primary care teams through evidence-based quality improvement coaching. Prior to joining the AMA, Linda directed QI programs in the ambulatory and home care settings and served as the administrator for a home health agency in Chicagoland, leading their operational quality outcomes and compliance activities. Dr. Curley and Nurse Murakami, I invite you to the virtual stage. If you could activate your mics and your video equipment, the stage is yours.
Thank you so much, Allison, for that warm welcome. And go ahead and advance to the next slide. Let's just dive right in. So I have the honor alongside Linda of really getting kind of nerdy with you all to talk about blood pressure measurement. And I suspect because you're all joining us on this summit today, that you're already very bought into the idea that improving blood pressure control around the country is really, really important. But just in case, I find this slide really interesting. We actually borrowed this slide from Hilary Wall, who's a lead scientist at the CDC's Million Hearts Initiative. And I think this is just a great slide to really put things in perspective. So you can see here along the bottom, common modifiable risk factors that we all think about when we're talking about preventing heart attacks and strokes. And then you can see the relative contribution that each of these issues makes toward the potential to prevent heart attacks and strokes. And so that you can see far and away, the most important issue for us all to focus on is improving blood pressure control in the country. So we can prevent more heart attacks and strokes if we really devote time and energy to this effort. And that is not to say less about cholesterol management, tobacco avoidance, tobacco cessation, all extremely important issues when we're thinking about approaching our patients from a holistic standpoint. But blood pressure control is that one issue where we can make the biggest dent. Next slide. So how are we doing in terms of blood pressure control at a national level? This slide here is looking primarily at NHANES data, and it's showing our blood pressure control rates over the past almost 20 years now. And so we're using here the cutoff of 140/90 millimeters of mercury as our determination for whether or not patients actually have achieved blood pressure control. And what you can see is that going from 1999 until about 2010, the country was actually steadily improving in its rates of blood pressure control. So we had achieved about a 53% blood pressure control rate as a country as of 2010. And then our progress sort of plateaued for a number of years. And unfortunately, what we are now seeing with the most recent data is that we're starting to backslide. So we are actually heading in the wrong direction in terms of blood pressure control in the country. And actually that last data point there showing 2017 to 2018, where we now are seeing a national blood pressure control rate of 43.7. That is actually just published in JAMA a couple of weeks ago. So that's some new information. And I would say for those of us who work day in and day out on blood pressure control, in some ways it's a little bit disheartening to see that. But at the same time, I think it represents a critical opportunity for us. And I hope that it really can actually serve as a clarion call for all of you to sort of become re-energized and again, refocus efforts on improving blood pressure control in our communities. Next slide, please. And thankfully, we do have tools, we have resources, we have approaches that have actually been shown to work when it comes to improving blood pressure control. For example, the AMA's MAP Quality Improvement Framework has been shown to improve blood pressure control rates within healthcare organizations. So the MAP framework, just in case you're not familiar with it yet, M stands for measure accurately. So making sure that we're obtaining the best possible blood pressure measurements so that we have good data to use when we make decisions about diagnosis and treatment for our patients. A is about acting rapidly and really avoiding therapeutic inertia and ensuring that our patients get the treatment that they need in a timely fashion. And then P is about partnering with our patients, supporting them in adhering to their treatment plans, and also supporting them in self-managing and self-monitoring their condition. Now, our MAP Quality Improvement Framework has actually been studied within healthcare organizations. We've seen that it improves blood pressure control rates by about 10 percentage points over the course of 6 months, and that improvement persists at 12 months. So again, we do have ways of improving blood pressure control that we can utilize here. And Linda and I, and really, the entire session today is mostly going to be focused on that M piece, that measure accurately component. Next slide, please. So why is blood pressure measurement so important? This is actually the most common procedure that we perform in medicine. It's something that we do all the time, and we tend to take it for granted. We feel like we've got a handle on it. But it turns out that measuring blood pressure properly is actually quite complicated. And unfortunately, it's a procedure where we tend to make errors that can actually bias our blood pressure measurements. So why is blood pressure measurement so important? First of all, blood pressure variability does exist in everyone. So even me, over the course of giving this presentation, my blood pressure is fluctuating a bit. And so it's not surprising that a single office-based blood pressure measurement ultimately correlates poorly with a patient's true blood pressure over time. In other words, a single office-based measurement is not very representative of a patient's bigger blood pressure picture. And then, as I was already alluding to, many office-based blood pressure measurements are taken with poor technique. So actually, there was a study done showing that there are 20 different sort of factors or steps where, if performed incorrectly, can actually bias our blood pressure measurements. So there is a lot to get right when it comes to blood pressure technique. Linda is going to talk a little bit more about that in a few minutes. And unfortunately, many office-based blood pressure measurements are not taken with proper technique. And then you layer onto this complicated picture the fact that there are different blood pressure phenotypes, like white coat hypertension and masked hypertension. And we really cannot elucidate a patient's blood pressure phenotype based off of single office-based blood pressure measurements. And so the whole picture is really that blood pressure measurements that are taken both in the office as well as outside of clinical settings, or what we tend to refer to as out-of-office blood pressure measurements, can and should be used to confirm a hypertension diagnosis and also to assess blood pressure control. And I think that out-of-office blood pressure measurement piece is really getting highlighted for all of us now in the face of the COVID pandemic. I know at AMA and AHA, we're getting a lot more questions about how do we do out-of-office blood pressure measurement? How do we do self-measured blood pressure with our patients? Well, we're going to touch on that a bit more today. But again, it all boils down to the fact that accurate and reliable blood pressure measurement really is needed to properly diagnose our patients and to manage our patients who do have high blood pressure. Next slide, please. So, Linda and I thought about this and we said, how can we boil this down to sort of the key ingredients for accurate blood pressure measurement? If you are thinking about this from an organizational standpoint, what are the sort of overarching principles that you want to consider when working to ensure that accurate blood pressure measurements are implemented in your organization? And so I would say there's 3 overarching principles. First of all, you want to make sure you're using validated and calibrated devices. Secondly, we're talking about optimizing your structure and your processes to make sure that they support accurate blood pressure measurement. And ultimately, you're creating an environment that allows for accurate blood pressure measurement. And then the third piece is the people part. So it's making sure that our team members, which includes our patients, actually receive training in how to perform blood pressure measurement properly, and that they receive that training regularly on an ongoing basis. Next slide. And then these principles of validated, calibrated devices, optimizing your structure and process, and thinking about your people, making sure they're trained, these principles apply to both in-office blood pressure measurement as well as out-of-office blood pressure measurement. And next slide. With that, I'm going to hand it off to my colleague, Linda Murakami, and I think Linda, before launching into her section, is going to kick it off with our first audience polling question. Thank you.
That's right. Thanks, Kate. So I'm going to talk about what it takes to obtain accurate blood pressure measurements, but first we're going to do that polling question. So Emily, you want to pull that up? So what blood pressure measurement devices are you using in your clinic? Multiple choice, you can select as many as apply in this polling question. So vote now. Thanks. And Emily, I'll let you control that because I don't see the poll answers or that part. So let me know when we're done. think we're still waiting for a few more people to vote, and then we'll get going. All right, so we can see that we have 31% using manual devices that are portable and 18 using the manual devices that are mounted, usually to the walls or a rolling stand. We have 44% on semi-automated devices and 22 on automated that takes multiple readings. Let's see, 44% have their multiple cuff sizes and a few of you are unaware, so great. Thanks everyone for participating. We appreciate that. And next slide, please. Let's move on. So regardless of what method of blood pressure measurement you're using, the use of validated and calibrated devices are critical for obtaining accurate blood pressure measurements. BP devices, they need to be validated, meaning the device was tested for clinical accuracy by independent skilled blood pressure measurement experts using one of the internationally accepted testing protocols. There's a new US blood pressure validated device listing, which is also referred to as a VDL, at the web address of validatebp.org. And this website will be updated with additional devices as manufacturers submit their devices for review. But there's also some internationally listed VDLs that we included on the slide, like the Hypertension Canada website and British and Irish Hypertension Societies as well. Next slide, please. And calibrated devices. So accurate measurements also rely on the use of calibrated devices and with calibration performed on a regular schedule. So you can see listed here that the automated devices, which are the electronic BP devices, are at the least frequently calibrated at every 1 to 2 years. But you can see manual devices will need more frequent calibration. So the wall-mounted manual devices is every 6 months, and the handheld manual devices, or the portable ones, are every 2 to 4 weeks, and more often if they're handled harshly. So every time it's dropped or tossed onto a desk or dropped into a drawer for storage, you know, just doing that can throw off the calibration and lead to inaccurate measurements. Often people use their biomed departments, and they're not necessarily calibrating, but they may be just checking for cracks and leaks in the tubing and in the cuff. But proper calibration includes a method of pressure testing. So you want to work, health centers, you want to work with your biomed departments and develop processes based on the guidelines for using proper methods of calibration. There are also, for those who don't have biomed departments, there are also third-party vendors who will provide calibration service on site outside the manufacturer. Next slide, please. So I'll talk about the different types of blood pressure monitors available, and we're going to start with out-of-office blood pressure measurements. Ambulatory blood pressure monitoring, or ABPM, has the patient wear the blood pressure cuff and monitor, usually for 24 hours. They program it to take blood pressure readings at set intervals. It's done while the patient performs their usual activities during the day and the night, and while the patient's asleep. It's helpful as high sleep blood pressure and the non-dipping BP at night. It correlates with increased risk of morbidity and mortality. And ABPM also has the most evidence from clinical trials for diagnostic accuracy and predicting future cardiovascular events. Self-measured blood pressure, or SMBP, that's when the patient takes their own blood pressure readings at home. And you can see that ABPM is the most reliable, and helpful for diagnosing hypertension, but both can be used in conjunction with in-office readings to rule out or identify white coat hypertension and mass hypertension and confirm the diagnosis of hypertension. So when compared with single conventional office blood pressure measurement, SMBP measurements taken over a week are much more predictive of future cardiovascular risk. And with clinical support and co-interventions, SMBP can be very effective at lowering blood pressure and improving control rates. So with many practices, currently performing virtual visits, SMBP monitoring can be incorporated into these visits to obtain blood pressure measurements. Patients can do SMBP for the week prior to the visit, or even during the virtual visit, for the provider. And I'll show you some tools and resources at the end that's going to probably help you with this. And an issue with ABPM, to make you aware, it can be hard to schedule. Not every primary care provider has an ABPM monitor in their offices, so you might have to refer to a cardiologist. SMBP here is probably the more convenient option and cost less. Next slide, please. So here's 3 methods used when taking blood pressure in the office setting. Manual devices, which I see, we saw several of you use. They're considered to be inconsistent and actually inaccurate. So while they're inexpensive, there's a lot of bias with these measurements. The observer who's taking the blood pressure, they might not pump the cuff up high enough, or they may deflate the cuff too rapidly, and that can affect the results. So there's also issues with terminal digit preference, and you already heard me mention their fragility and the need for frequent calibration. So when looking at incorporating new devices in clinical settings, consider the guideline recommendation of using automated devices over manual methods, and it removes that human bias involved in those manual BPs. Semi-automated devices will take one measurement after the push of the start button, and they often come in that all-in-one with the pulse oximeter and taking temperatures. The automation makes the measurements not as likely to be affected by variations in technique or human bias, and are better able to be reproduced than readings taken manually. So there's no longer issues with not pumping up the cuff high enough or deflating that cuff too rapidly with these methods. Automated office blood pressure, also known as AOBP, they're fully automated devices that can be set to take multiple readings with a single activation. Most times they're set to take 3 readings 1 minute apart, and then those readings are averaged automatically by the device. So because of the programming ability, readings can be taken unattended, and that means the staff can leave the room after starting the readings and allowing the patient to be alone. And this helps reduce that white coat effect. Next slide, please. So we have another polling question here before we cover tips and best practices. So Emily, are you ready? Okay, so what are some common errors in taking blood pressure readings? So pick your best answer here. And we'll keep this up until the majority of people have answered. So log your answers now. All right, so here we have our answers. What are some of the common errors? We have using the wrong cuff size, and we'll talk about that for sure. And the patient's arm is lower than heart level. And all of the above for that 80% that the patient has a full bladder, which no one selected singly. Thanks everyone for participating in that one. All right, we can go to the next slide. All right, so staff training. Staff training, the AHA scientific statement on blood pressure measurement in humans tells us that initial and ongoing training of technicians and healthcare professionals is necessary for obtaining accurate BP measurements, and I can't stress that enough. So leaders, you should develop proper training of your staff to take these BP measurements accurately. You should do initial training, and then retraining should occur. You need to include competencies, and these should actually be done every 6 to 12 months, which is the recommendation in the guidelines. Next slide, please. So we mentioned incorrect cuff size. Using the incorrect cuff size is the #1 error in measuring blood pressure. So cuffs that are too small can give falsely high BPs, and cuffs that are too large can give falsely low BPs. So as part of ongoing staff training and competencies, we need to make sure they're trained to measure the patient's upper arm circumference to make sure we select the correct cuff size in office and for the patients using self-measured blood pressure. Next slide, please. Okay, so now that we have the correct cuff size, correct cuff placement should be done properly. So be sure to include this as well as in your staff training. Upper arm cuffs should be placed on the patient's bare skin, and staff can educate patients each time they come in to wear short sleeves to their apartments or wear them under a sweater or something, you know, if it's chilly outside. For in and out of office, the cuff should be tight enough when it's applied to fit one finger at the top and the bottom, or two fingers can slide and fit snugly underneath. Next slide, please. So, talking about patient preparation, staff need to prepare their patients for the BP measurements, and regardless of if it's in office or at home, caffeine, exercise, and tobacco products should be avoided for at least 30 minutes prior to the reading. So that will also require some patient education. So you want to educate them at each visit and remind them before they come not to, you know, exercise, drink caffeine, have that coffee in the car, and not to smoke that cigarette right outside the door before they come in. And then you want to train your staff to have the patient empty their bladder in rest and quiet environment. So we're going to rest 3 to 5 minutes in the office setting and 5 minutes at home. And if you can't rest the patient in the office, the staff makes the blood pressure, taking the last blood pressure, the last thing they do prior to the provider seeing the patient. So, next slide, please. All right, patient positioning. So patient positioning is a very important consideration when we're talking about measurement accuracy. So the patient's positioned in the same way, both in the office and at home. So you can see we're gonna sit them in a chair with their back supported, their legs uncrossed, with their feet flat on the floor. If they can't reach the floor with their feet flat, we should put their feet on a step stool. Their arm needs to be supported, usually a table or a desk, and use that proper cuff size that I mentioned on bare skin. And then with the propping of the arm on that table or desk, we want to make sure it makes the cuff, the middle of the cuff, be at heart level. So these are all very important. We're going to show you next slide, please, and explain why all these matters. So this is what the effects of the improper positioning can do to blood pressure results. So we need to be really concerned about the impact of these errors, because we can have, you know, a few millimeters of mercury, or even at 10 or more, could be the difference between diagnosing the patient properly with hypertension, or, you know, we might lead to overtreatment if they're falsely high, and we know that's a huge concern, especially with the elderly population and patient falls. But, you know, let's point out that, you know, cuff over clothing can affect the blood pressure from 5 to 50 millimeters of mercury, and that is tremendous difference. And even just, you know, full bladder and talking and the unsupported arm, that's 10 millimeters of mercury. So we really need to pay attention to these changes in positioning. Next slide, please. So when we train staff to do proper measurement, and the same is needed for patients as well. So we want to make sure they're measuring blood pressure accurately at home. So we're essentially training the patients similar to the staff, preparing, positioning, and doing proper cuff placement. Also here, patients need to be taught how to measure and how often to measure. So they want to take usually 2 blood pressures, 2 sets a day. You're going to do 1 minute apart, and we're going to take 2 blood pressures in the morning and 2 blood pressures usually at night before they go to bed. And most are directed to take readings for 7 days before an appointment, or when adding and titrating blood pressure medications. So you see if they're working. And again, if you're going to have patients use SMBP during virtual visits, you know, this can be done for them to train before, if they've never done it before. We know sites and clinics have had MAs call their patients before virtual visits to talk them through it if they have a device at home, making sure they're doing it properly, or they can do it, like I said, during the visit itself for the providers. Next slide, please. So here's an example of how an exam room can be set up for accurate measurement. Exam rooms are usually designed with that panel of devices on the wall, and that usually includes the Aneroid blood pressure, manual blood pressure device over the exam table. So, but the device should be at eye level, so moving it by a chair, by the table for arm support allows for a better reading. Chairs with back support and armrest can be used for arm support, but with taller people, you're probably going to need a table. Those arm rests are too low for them. And if you can't put the chair by a table, if you don't have a desk or a table in the exam room, you could consider moving the chair to the end of the exam table, and you can use the exam table itself or the footrest that pulls out for arm support as well. So those are just a few ideas to help you reconfigure exam rooms. Next slide, please. So we're just going to review some tools and resources. All of these tools and resources can be found on targetbp.org. Next slide, please. So here's the Measure Accurately Quick Start Guide. It can help you get started and outline a plan for improving your blood pressure measurement accuracy. And then to help patients with training and staff with training, we have a technique quick check that allows you to do some sporadic spot checks on the staff when they're doing BP measurements, you know, with their patients and positioning. It also has criteria for that. And also there's competencies for all three types of in-office blood pressure measurements. Next slide, please. So these are a couple of, we think, are great graphics. SMBP graphic is on the left, it's in blue, and it helps guide the patients in preparing, positioning, and measuring their blood pressure. So we suggest patients hang this up in the area, if it's in their kitchen or their own personal office or bedroom where they're gonna sit and measure this. We advise hanging that up. And then the red one on the right, the 7 simple steps graphic is for in-office blood pressure measurement. And we know there's a lot of health centers across the country who actually hang these up in their exam rooms to guide the staff. It also allows the patient to hold staff accountable to make sure they position themselves correctly. But it's got bubbles around it that, you know, you can see tells us the differences in the millimeters of mercury when not positioned properly. And next slide, please. So here we also have an SMBP Quick Start Guide, and there's a patient training video for SMBP. It's in English and Spanish on the targetbp.org site, and the link is also there. And then there's a short 15-minute webinar on SMBP, also can be used as a podcast that you may also find useful. And so I think this is ideal for those of you who are trying to incorporate the virtual visits in with your patients to give them some quick, good training on how to measure their blood pressure at home. So I'll hand it back over to Kate, and she'll talk about the e-learning modules. Thank you.
Next slide. Thanks. So Linda was just talking about that red graphic that reminds the care team about the proper steps and positioning and patient preparation for accurate BP measurement. Really, we turned that idea into a 30-minute e-learning module that is eligible for half a CME credit, and it really takes sort of the AHA scientific statement about accurate blood pressure measurement and makes it more living. So really walks the care team member through the detailed steps and proper technique of accurate BP measurement. This is the only tool, I just want to note, that does have a cost associated with it. So a user license is $25. We do have some bulk pricing for organizations that want to purchase several licenses, and our team is happy to connect people with that if interested. But we have shown that this module actually improves users, not just knowledge, but hands-on skills at blood pressure measurement. So next slide, please. And as Linda already noted, all of the tools and resources that we have just talked about are available at targetbp.org. And next slide, I think with that, I'll conclude. Thank you all.
Thank you, Kate. Important topic. We have just 1 minute for a quick question or two, but the importance that you covered in both the importance of accurate devices, the importance of training your staff in technique regularly, and creating an environment, an exam room, and procedures that support accurate measurement, they're all equally important in delivering accurate blood pressures for every patient every time. So just one quick question I want to ask, which is really explaining sort of the difference between an FDA.
So Allison, you may have frozen on my screen. I'm not sure if that's true for everyone, but I think your question is the difference between the FDA approval versus the
FDA approved device versus a validated device. And there was a question that came.
Yeah, great question. So FDA, the 510K approval process for devices really is meant to ensure sort of safety and effectiveness of devices. It does allow manufacturers to essentially use validation data not from that device itself, but from similar, oftentimes older devices. So many of the devices that are FDA approved and out on the market actually have not been independently validated for that device itself. So the validated device listing, a initial bar is that the device needs to go through the FDA 510K clearance process and needs to be FDA approved. But then the validated device listing does the next step of verifying that there has been an independent validation of clinical accuracy that has been done on that specific device.
Thanks, Kate. That was really helpful. Again, thank you both. I wish we have a few, but I want to move on to our panel. I also want to remind all of you, before you leave the event today, to please take a few minutes to provide feedback through the evaluation form. That really will help us plan the remainder of the events and ensure that we're addressing the most pressing needs for you and your clinics and your patients. The link will be provided in the chat for your reference. So moving on, I really I'm excited to introduce Accurate. I want to introduce our 4 panelists and our moderator. First, Dr. Kevin Wong from UT Health McGovern Medical School in Houston. Dr. Wong joined the Department of Internal Medicine at the University of Texas Health Sciences Center at Houston's McGovern School of Medicine in 2005 as a primary care fellow and became an associate professor in 2013. He also serves as medical director for UT General Internal Medicine Center and the University of Texas at Houston Memorial Hermann Center for Healthcare Quality and Safety. Welcome, Dr. Wong. We also want to welcome Dr. Michelle Bosworth from UT Health Tyler. Michelle Bosworth has been with UT since 2009 and is currently serves as the Executive Director of the Center for Population Health Analytics and Quality Advancement for the School of Community and Rural Health. Her academic appointments include Associate Professor of Family Medicine as well as Healthcare Professional Policy, Economics, and Management. She is board certified in both family medicine and clinical informatics and previously served as the Chief Quality Officer and Chief Medical Officer for UT Health Northeast. Welcome, Dr. Bosworth. I also want to welcome Dr. Gianna White, currently serving as a medical director for the Disease Control and Clinical Prevention Division for Harris County Public Health, the 3rd largest county in the US with a population of more than 4.7 million people. Dr. White joined the department in March of 2019 and currently oversees several public-facing community programs, including immunizations, refugee health screenings, family planning, tuberculosis elimination, human HIV, and other unique medical services. Prior to joining, Dr. White trained as an internist and pediatrician throughout the Houston area and has more than 20 years of experience caring for patients from birth to end of life. Welcome, welcome, Dr. White. Our 4th panelist, Dr. Jacqueline Phillips from Amistad Clinic in Corpus Christi, has been working as the Chief Medical Officer in Community Health and Primary Care, a local health FQHC in Corpus Christi, Texas. Again, where she serves as Chief Medical Officer. Under her leadership, they have grown to 13 providers offering a wide range of physical and mental health services to over 12,000 patients. She's been named Resident Educator of the Year, HER Medical Hero, and a Corpus Christi 40 under 40 honoree. She is a graduate of the Leadership Corpus Christi Class 46 and served on the steering committee for LLC Class 48. Welcome, Dr. Phillips. And last, our moderator, Dr. Robert Morrow from UT Health Science Center of Public Health, an executive in residence. Dr. Morrow is currently serving as a part-time faculty and executive in residence at the University of Texas Health Science Center at Houston School of Public Health. Before joining the School of Public Health, he served as the market president of Houston and Southeast Texas at Blue Cross and Blue Shield of Texas. As a champion for public health, he's on the board of directors for the Houston division of the Southwest affiliate of the American Heart Association, and he's currently serving as president there. At this time, I ask Dr. Morrow and all the panelists to the virtual stage, activating their cameras and microphones. Welcome and thank you.
Well, thank you very much, Allison. So happy to be here, wherever here happens to be for everybody. And so let me, as we get started with this robust panel, let me just say a few things. One, I want to really thank the American Heart Association and the AMA for convening, well, the conferences and now this sort of expanded conference around blood pressure, because I think it's critically important. I think one of the slides that really reached out to me early on in Dr. Curley's presentation just a bit ago was the bar graph slide that showed really the relative importance of blood pressure control when it comes to heart disease and stroke. And if that isn't sort of serve as, in my opinion, a pretty compelling call to action, I don't know what else will. So I am very blessed, obviously, to be joined with this panel. In the interest of time, we're going to get sort of straight into questions. And given the format, we're kind of I'm going to really almost ask every panelist to answer each of the questions, particularly if they have anything new, different, or another slant on a question to add, unless or until we tend to run out of time. I think as mentioned earlier, if you have questions, you can put them on chat. I am sometimes a bit technology challenged, so I might have an issue both reading chat and moderating the discussion, but I will do my best, and I'm pretty sure I've got some help. So with that having said, I'll start with questions. And the first one, and I'll do this, I'll sort of go in a little bit of an order and change it up as we go. So Dr. Huang, one of the things I'd like, and this will go to each of you, could you tell us about sort of a little bit more specifically about your role, and then in that context, any systematic or policy changes that you have made or have participated in your organization to measure blood pressure more accurately?
Great, thank you. Can y'all hear me? Okay, great. So I work with a number of people and other leaders in the institution, some of which are on this panel and have been working together for a long time working on blood pressure. So just kind of an unofficial leadership role, but I work with a lot of people on it. So over the years, we've worked with clinic staff and medical directors of various clinics and nursing leadership to really promote the importance of correct blood pressure measurement in the office. And we've done this through formal presentations and also informal meetings and conversations. So, you know, one of the first things we did was just trying to improve the staff training processes for blood pressure measurement. And so we have training on initial hiring and then booster training sessions. And we also worked on getting some better machines. Some of the clinics we have now outfitted with the automated office blood pressure machines that were discussed in the first presentation today. And we've also worked with a cardiologist to make ambulatory BP measurement more easily ordered and available for our patients.
Well, that's outstanding. You know, I will add, in monitoring the chat earlier on, I would just point out that for the participants on today's webcast, that the timing, the actual training of appropriate or accurate blood pressure measurement seems to be all over the board from the folks in here. So hopefully at the end of this discussion, maybe we'll all be coming a bit more together in terms of how often, how accurate, and to what extent we offer training to the people in our particular clinics or settings. So Dr. Bosworth, I'll ask you sort of the same question. You know, your role, any systematic or policy changes that y'all have made in terms of promoting more accurate blood pressure measurements?
Sure, thanks, Dr. Morrow. We certainly have implemented, you know, one of the questions from the presentation earlier was about how much training staff received throughout their institution. And one thing that we did is we actually implemented annual competency training using the Target BP methodology for all of our clinical staff that do blood pressure measurements. And we will do refreshers as needed. And of course, new hires will get trained in that methodology as well. So that's one thing that we did implement. We are working on in discussions with cardiology about the ambulatory blood pressure reading process. We don't have that quite figured out yet, but I know one of our cardiologists is especially interested in that.
Outstanding. Dr. White, similar question.
Can you hear me, Dr. Morrow?
I can, very good.
Okay, awesome. So as new to the organization as medical director, one of the things that we were happy to work closely with Heidi and the Target VP team was that we were able to identify clinical champions, what we called it. We implemented sort of the clinical champions at each of our clinical locations to help us support in these leadership roles to really assist in sort of facilitating a model across all programs that support the importance of checking blood pressure. So that was exciting. Our nurses were very much on board and have taken this and run with it. They actually are now part of our confirmation of how we look at calibrating our equipment and validating the equipment throughout all the programs. And again, this is bringing the importance of these requirements are necessary to support how effective we can be with evaluating blood pressures. We've also really brought to light our program managers and program directors to understand that these champions, these nurses, these team members will be coming to them with this sort of subject matter expertise. And so with that, they've been able to also identify the machines that need to be updated, what that looks like, how messaging will look in the clinics. We've utilized some of that educational material, and really it's just a massive effort for our nurse champions to say this is extremely important. So we're excited about that. And we've also leveraged the opportunity to take all of our practice providers, including our employee health, and saying that all these different touch points for patients and staff are important to give the message about the importance of checking your blood pressure.
That's outstanding. Clearly a lot of work being done. So Dr. Phillips, any systematic or other operational changes in your arena that y'all have either implemented or are implementing with regards to making sure we're measuring accurately?
So when I took my position within Amistad, we evaluated our UDS measures to see where we were at in terms of our hypertension control and found out that it was overall poor. So we did a systematic review, and one of the things that we had been using in our clinic was the portable automated blood pressure cuffs that were getting dropped, that had already lost half of the bladder-sized sleeves. And once we decided to first tackle that issue, we looked and got a grant to replace all of our blood pressure cuffs with the wall-mounted automated office cuffs. Then the issue became we needed to instill some type of training for our MA staff. So we did educational sessions on how to accurately take blood pressure. And now we have a standing policy that twice a year MAs need to go through a competency checklist. Every new hire needs to go through a competency checklist for checking blood pressure. And then as well, our patients, when they're brought into the room, if their blood pressure is high on the first read, all MAs are instructed to let the patient relax in the room for a while and then recheck that blood pressure 30 minutes later. Once the patient has relaxed, they're in the appropriate position, and we get a recheck on the blood pressure. The one thing that we have found systematically that we're trying to change, but it's really patient dependent, is making sure that our patients take their medications before they come to the office. I think sometimes that's the biggest hurdle that we have. So now we have instructed all of our receptionists and schedulers staff to, when a patient is coming in for an appointment or when we are confirming their appointment, that we remind them, please, it's very important, take your medications on the day of your appointment. So we're going to try to see if that helps with improving our blood pressure control.
Outstanding. One of the things that actually I believe was talked about in our intro by Dr. Curley, Ms. Murakami, is the importance of calibrating the equipment. And I know Dr. White, you specifically mentioned making sure that the equipment is calibrated. I confess in my family medicine clinic when I was in full-time practice, I did not routinely ensure that my equipment was appropriately calibrated. And I'm just going to throw this open to the group real quick. Any tips or tricks or things that you're doing to make sure that your equipment is appropriately calibrated? Dr. Phillips, perfect.
Our center employs now a monthly environment of care document. So this covers everything within our center down to our machines calibrated, and there is an assigned MA that is supposed to make sure that the blood pressure machines are calibrated, the EKG machine is working, the AED is working, and we go through a checklist. Anything that is red, meaning that it has not been signed off or it hasn't been reported that it's calibrated or up to par, we drill down on and make sure that we get it to where it needs to function. So once a month, we do an EOC report, an environment of care.
That's perfect. Anybody else want to tag on to that? Any other tips or ideas?
And this is Dr. White. I know we have a biomed team, but I like the last speaker's strategy. One of the things we're also implementing with the Target BP initiative is that now that the workforce knows that that's an expectation, that they almost are okay with reminding us if they see it hasn't been completed. So for instance, with COVID, we've had a lot of things that have gotten pushed back, but now with the champion saying, I know, this may be another issue with COVID, but our biomed review is a week late. We think that's going to be a nice support.
Perfect. Thank you. So the next sort of question I'm going to get is a bit more general, and we'll address it again to everybody. But the question is, what are some of the biggest challenges you've seen in terms of improving BP? And I would open that sort of question up to both in your clinics or your offices, but also maybe even with your patients who are outside of the office setting. And this time maybe start with Dr. Bosworth.
Great, thanks, Dr. Morrow. So I love what Dr. Phillips said about getting patients to take their medicines before they come. Seems like for my whole career in medicine, patients have been groomed not to eat or drink before they come to the doctor because they might have labs or something done that they shouldn't have eaten or drinking. And so then if they haven't done that, they haven't taken their medications. And so then they're coming in and we're getting blood pressure readings that are not reflective of what the treatment is actually imparting on control for their blood pressure. So I think that's a huge challenge, and I am going to follow up with our patient reminder, clinic reminder staff actually, and see just what Dr. Phillips was saying is that are we scripting that to make sure patients are told to take their medicines? But from from a practicing standpoint, when I see my patients, they're still not taking their meds before they come, and even though I personally have told them to do that, so I think that's a huge challenge, and I'm so glad Dr. Phillips brought that up. I think there is, even though we've had Target BP training, I think there's still pressure for patients to get roomed very quickly. And so there's, just demands on primary care in general, so many things. And I love the Target BP methodology and making sure you're doing things correctly, but even the fact of trying to get a patient to empty their bladder before you check their blood pressure, that could add minutes onto the rooming process. So I think that is still a big challenge of actually, measuring those blood pressures correctly. One thing that I have noticed, I have a large population of mature female patients, and a lot of them are not adherent to, especially the diuretics, because of other urinary incontinence issues that they might have. So I think just medication choice becomes an issue that may not be readily kind of visible to a lot of physicians thinking about that with their more mature female patients and those issues with diuretics to treat their blood pressure. I obviously think health literacy is a huge problem as well. I still, there's patients who, because they take a pill, they don't think they have a problem, and so they don't believe they have blood pressure because they take a pressure pill. And so getting them to understand how that still correlates with, yes, you still have hypertension, this still increases your risk for heart attack and stroke and other cardiovascular disease. So I think we still have some ways to go with that type of health literacy. And then I had a patient I saw yesterday who, had been off his blood pressure meds because he just simply doesn't have a car. And so we always have to bring in those social factors in terms of transportation and, affordability for meds, et cetera. So big question with a lot of answers.
Yes. Well, no, great thoughts. And I, we could probably spend an entire discussion just on challenges, and we will keep going a little bit on that. Dr. White, anything from your perspective, sort of specific to challenges in terms of improving BP measurements?
I think for us, many of our team are first responders in the sense of public health and COVID. And so what we're finding is, again, what the speaker just mentioned about the time, and that the patient's touch point feels that they don't want to have a lot of time. They want to be in and out with PPE and protective support, but also the clinical staff is also being mindful of how much time they're in front of a patient. So there's the sense of acknowledging the value that it's still important to do those vitals. It's still important to have that information as part of the visit, even though we also recognize we're trying to limit the amount of touch point we have, how this looked a couple of months ago and how it's looking now with COVID.
No, great points. And we might get into a bit of a discussion about COVID again in a bit. Dr. Phillips, anything to add to this particular part of the discussion?
So one of the things that I want to say is thank you so much for a lot of you having the same problems that I have been seeing, because it makes me feel like I'm not having a lot of shortcomings as a doctor, because we all experience it. So also in the patient population that we serve, reliability of follow-up is sometimes an issue. And there is some expectation to where some patients feel, well, I don't need to come in for monitoring. You should just call in all of my medications for an indefinite amount of time. But you need these patients to come back in, and you need to check their lights, you need to check their renal function, et cetera. So one of the policies that we put in place is our refills are usually for 3 months if it's a every 3-month follow-up, or 6 months respectively. But then in order to prevent people from coming in on month 4 saying, well, I've been without meds for a month, we do have a standing policy now where when you call, you get 1 month of refills, encouraged to make an appointment. And then after that month, if you have still not made an appointment, we will call you and say, we're going to refill you up until this date, and you have an appointment on this date, so you must come in and please take your medication so that we can get an accurate idea of how your blood pressure is. So I think the refill policy has helped us somewhat.
Great tip. Dr. Huang, anything to add?
I was really glad to hear all of y'all talk. I know that Dr. Phillips and Bosworth mentioned about challenges in patients not taking their medication. So, we deal with the same thing. So some of them still have the old school mindset where they skip their medications before doctor's visits. I think ultimately the challenge that I've seen and I've discussed with my colleagues here is that we're dealing with people, and people, like in terms of the people who are working in the clinic, they're not robots, which is good, but it's also challenging because everyone's working under a lot of different priorities and directions and time crunches, and education on how to measure blood pressure, just education and training and checking off competencies and having the right equipment is necessary, but it's not enough. Ultimately, people have to have the time, and they have to prioritize it. And so and we know that measuring blood pressure correctly takes more time and effort than just slapping on a BP cuff and taking the first measurement. Taking the time to position the patient correctly, to remeasure it at another time, to take multiple measurements, and to enter those measurements into the EHR, all of those take time. And it's not the path of least resistance. It's the path of the most resistance. So it's a continual effort to remind and encourage, everyone involved in blood pressure measurement on how to do it correctly and how important it is for patient care.
I mean, great tips. I mean, from all of you. And so, Dr. White, you've actually done a good job of being a lead-in for me for moving on to the next question. So I'm going to maybe throw this one out to you first. COVID has certainly and without question impacted every one, not only of our personal lives, but our professional lives. And I would say particularly in the healthcare professions quite extraordinarily. I think I've heard an unprecedented number of times when it comes to COVID. So I'd be real, and you started down this road a little bit ago in terms of strategies or innovations that you might have implemented or things you've had to do, quite frankly, in the context of our response to COVID this year, and specifically as it pertains to helping patients manage their blood pressure.
We've definitely taken a concerted effort to make sure that the messaging we're giving out talks about COVID and how it impacts when you have additional comorbidities. So we talk about the high blood pressure and having controlled pressure to know, how you would negatively be impacted if you were to get COVID-19. So we've done a lot of social messaging. We've got flyers. Our community health workers are really out in the community talking to people, organizations, faith-based, school-based, really just getting that information out and utilizing that to help inform and make sure that the community understands the impact that these comorbidities have if you were to in fact have COVID. The other thing that we've also had to consider in the midst of COVID is even how to pivot and offer additional services. So for instance, when we were really never a telemedicine type of provider. We had to switch, and I think the other speaker also spoke about how you deliver medications and allow for an additional month or two when you normally would not have done that. And so for us in family planning, for instance, with our refills on oral contraceptives, we have a sort of a drive-through model of refills, but we instituted in our drive-through model the ability to check your blood pressure before you could sort of get your medication to have another place to talk about that in the midst of COVID. So it was just an opportunity for us to just really think differently about it.
Oh, great thoughts. And you mentioned telemedicine, which it's hard to talk about healthcare in the COVID world without talking about telemedicine. And I actually had been surprised prior to COVID at the relatively slow pace of adoption of telemedicine, really pretty much across the healthcare system. And I've also thought prior to COVID that one of the best applications for telemedicine happens to be in the control of chronic disease and the ability for clinics to effectively monitor a patient population who really doesn't need to come into the clinic. And so one of the maybe I'm hoped for silver linings on all this is not only our peers who are providing healthcare, but also our patients who are receiving healthcare becoming more comfortable with and more adept at utilizing telemedicine for appropriate care. And I think particularly in the arena of chronic disease. So with that as a backdrop, Dr. Phillips, anything that y'all have done or are doing specifically with regards to managing high blood pressure for your patients in the current environment?
So when COVID became an issue, we pivoted to telemedicine, I think like everybody else did. And some patients did very well. Some patients did not do very well. I mean, there is, just like there's a level of health literacy, there's also a level of comfort with technology. and even access to resources. And I think access to resources was probably one of our biggest hurdles, because a lot of our patients go to HEB and check their blood pressure, and they go to CVS to check the blood pressure, and they don't have monitors at home. One of the things that we did was we partnered with one of our payers, and we received a grant through our payer, and we utilized technology to marry with our EMR. So we started a remote patient monitoring program. We purchased blood pressure cuffs and glucometers, because diabetes and hypertension are two big disease states in our clinics, and educated these patients via Zoom how to upload this information into our EMR. And then we assigned two nurses to specifically go in and weekly monitor these patients. And it's actually helped us target their blood pressures in real time. So in real time, we're able to see, hey, your blood pressure was high. And when we call them, they say, well, I ran out of my medication. So we're able to give that refill in real time. Hey, your blood pressure is high. Well, my blood pressure's medications haven't been working, and we're able to adjust it in real time. So it was a little bit of a experiment to find out which equipment would give us the biggest bang for our buck with our EMR, and then also the education with the patients. But the patients that we have targeted for this have been very engaged.
That's awesome. Dr. Huang.
Yes, that's great. You know, I'm really impressed hearing what y'all are doing, working with patients for remote monitoring. So similar situation, we did expand telemedicine pretty rapidly. We went from a few specialty clinics to the majority of our adult primary care clinics. So while that was helpful in, you know, hearing about how patients were doing at home, we haven't yet had widespread adoption of bringing in home blood pressure readings directly into our EHR. We ask informally, we look at logs, we might observe patients measuring it, you know, right there in front of us, although that brings to mind a strange type of white coat hypertension. It's like virtual white coat hypertension. Sometimes the nurses will remind them to take a couple of blood pressure measurements in a few days before the virtual visit, and so we'll work on that. One of the challenges that we have is that we are switching to a new EHR. So a lot of our resources have been rightfully so focused on optimizing that implementation. We're hoping that when we go through this change, we'll have a better ability to bring in home blood pressure readings and glucose readings and body weights directly into our EHR.
Excellent, great thoughts. And Dr. Bosworth, particularly with your background in clinical informatics, anything that y'all have implemented or that's new or different or seems to work particularly well in the current environment?
Sure. So, you know, we've done the telehealth visits, and we actually were a little bit ahead of the curve with telemedicine. Right before COVID, we actually had implemented some telepsychiatry. And so this was kind of right up our alley when this hit. So we actually, our infrastructure was in place a little bit better, I think, suited for most organizations when COVID hit. But one of the things that we do in the center is that, you know, we're housed to all of our district programs, and then we also have a Department of State Health Services funded programs for blood pressure, SMBP, you know, blood pressure management, cholesterol, and the diabetes prevention program. And so we have previously, prior to COVID, we're offering hypertension workshop program free to patients. And this was a 10 to 12 week program that was previously person. And so we switched that to Zoom or virtual meetings. And really, it has created a social savior for a lot of our patients who otherwise have been isolated due to COVID. And I think, you know, so it kind of had a secondary benefit. And even after COVID, we plan to still continue to offer virtual workshops because it has been so well received. In these workshops, we will have to see them probably at least once, but so they can get their free blood pressure cuff. So we do offer them a free blood pressure cuff so they can do their home readings themselves. So, and that's probably the only, I think, big things that we're doing.
Perfect. No, thank you so much. And I feel like we could keep going on this topic as well for almost the rest of the afternoon. We only have a few minutes left, and I'm going to switch gears only slightly and talk about a topic that I think is incredibly important. And unfortunately, the COVID crisis has, I think, sharpened the focus on the concern with regards to health inequities and the idea of really addressing social determinants of health and their impact on the overall health of our communities and our populations. So I want to just as briefly as possible, because again, we only have a few minutes, talk about strategies that are either being implemented or considered for promoting health equity specifically as it pertains to hypertension control. And Dr. Phillips, I'll start with you.
So to kind of address some of these issues that we were having, I mean, namely, really one of the biggest ones was when we switched to telehealth. Ideally, you know, I know you're able to do telephone visits, but you also want to have some type of video component with it. And we were able to kind of enact some type of, and this is going to sound very rudimentary, but like almost like a HEB curbside type style, to where if a patient needed to have their blood pressure checked and they did not feel comfortable coming into the clinic, they were able to go and park into a spot and call us to let us know that they were there and what spot they were in. And we had a team that would go out to take measurements if needed. If patients had lack of transportation, because transportation is probably our biggest issue, especially with our clinic, we have a care van that we're able to have a nurse practitioner that is able to drive out to some of these sites and get blood pressure readings or be able to evaluate a patient if needed. So transportation was probably our biggest issue, and probably lack of technology was probably our biggest issues that we tried to address in terms of control of blood pressure.
Perfect, thank you. Dr. White, Harris County Public Health, what things or you either are doing or contemplating or planning with regards to promoting health equity in terms of hypertension control?
So right now, our biggest effort is to aligning sort of the entire organization. We have a chronic disease division, and we have several other areas where we are really saying, okay, how can we align this across all of our touch points where we have external interfacing with the community, even as we look at our environmental teams, our veterinary and public health teams. And in that, we want to make sure we have messaging that has literacy and different languages, that way we're giving information to basically as many populations in our community that have the ability to have access to that information in their native language, if that makes sense. So we have English, we're working on Spanish. I know the posters we have with Target BP, we've asked even, can we have them translate into additional other languages that we have up in our clinic settings. So we're really taking a big initiative on what it would take to take our communication efforts and sort of put some money behind it to have things translated.
Perfect, great job. So we're almost out of time. I'd ask Dr. Huang or Dr. Bosworth to either one or both chime in real quick on any opportunities to more meaningfully address health inequities and hypertension control.
I'll just add real quick that we have had some loaner devices being offered at some of our clinics before COVID came into town. So we're continuing that. And some of our clinics, well, all of our clinics have a mixture, but they're not all the same. We have community health workers and case managers and health educators who take the time and effort to reach out to patients and help them understand hypertension, understand the challenges that they're that they're struggling with in terms of measuring blood pressure at home or taking their medications. As we probably all can recognize, this whole COVID pandemic has caused a lot of stress and anxiety on multiple levels in everybody, regardless if you're positive or negative for COVID. So there's also a study going on where we're learning more about the burden of depression and anxiety in our patients, and expanding our resources for telemedicine, for psychiatric and psychological counseling for people who need help.
Perfect.
And that obviously affects blood pressure control as well. So
yes, yes. Dr. Bosworth?
I'm just going to say real quick.
You get to wrap us up.
Okay, great. We utilize community health workers, and they help our patients with care navigation, improving health literacy, health equity, getting them plugged into services or resources that may be identified in any social factor assessments. And one other thing that we do have is a lending library, and so we actually have blood pressure cuffs that patients can check out for free. And it's kind of like a library, and then they can turn it back in when they're done. So that'll wrap us up.
Well, thank you so much. And let me just real quick thank all the panelists on my behalf. I have the easiest role when you have great experts on your panel. Really, all you have to do is shuffle questions and magic happens. So thank you all very much. And I believe, Allison, I'm going to turn it back over to you.
That's great. Thank you all so much. Dr. Morrow, thank you for facilitating the panel. Dr. Phillips, Dr. White, Dr. Bosworth, Dr. Wong, I really appreciate you sharing so many insights, but the challenges and the solutions that you found that work in your clinic with your patient population. So thank you. That was really invaluable. We're going to just take a few minutes before wrapping up here. I want to share some exciting new updates for the 2021 Target BP Recognition Program. I realized with the extended data submission deadline that it feels like you just did this, but 2021 will be upon us, and I'm excited to share a preview of what's to come, and it ties directly to the conversation that we've been having today, both the presentation by Dr. Curley and Nurse Murakami and the panelists and their reflection on the challenges of blood pressure control. So if you could go to the next slide. We're excited to announce a set of new award categories based on evidence-based blood pressure activities that fall into these three categories, which you've heard discussed today in a number of ways around equipment, calibration, and validation, and the importance of selecting validated devices, as well as calibrating them according to the BP scientific statement, the manufacturer's guidelines, based on whether they are aneroid or oscillometric devices. And then the second category is around staff knowledge and skills. We've talked about the importance of training staff in their knowledge of blood pressure measurement, as well as testing their skills on a regular basis. Again, the scientific statement recommends every 6 to 12 months. And then the last category is around systems of care. Are we using a protocol to obtain a representative blood pressure, either through confirmatory measurements in the office, through the use of ambulatory blood pressure measurement, or through self-measured blood pressure? And then lastly, using some type of visual cue like the in-office positioning graphic, finally known as the red graphic, next to any of the device measuring stations, so that there's a visual reminder of the importance of technique. So this is sort of a very distilled description of these important activities, and I'll show you on the next slide how those filter into some of the new award categories. So you're familiar with the participant and gold status categories. Those will remain the same. There will be two new categories represented here in the silver and the gold plus. So organizations who submit their data and demonstrate those evidence-based blood pressure activities that I just described will be eligible for a silver award, even if they have not yet reached the 70% or greater control rate threshold. Those who have reached that threshold and also demonstrate those evidence-based blood pressure activities will be eligible for a Gold Plus award. Each organization will only be eligible for one of these 4 awards, but there's some new opportunities to demonstrate your commitment and your excellence in blood pressure measurement as well as control. So we're very excited about that. If you could go to the next slide. I just want to give you a heads up that on September 30th, Target BP will be hosting its monthly webinar on measurement of blood pressure. and Linda and Kate will be presenting again, but in a little bit more depth, and they'll be highlighting some of the more specifics that will help you and your institutions achieve those evidence-based blood pressure measurement criteria and then be eligible for the award. So just like your your blood pressure data from 2020 is what influences your ability to achieve the award in 2021. The same is the case for these activities. So I encourage you to attend that webinar. There'll be free CME CE credit, and you'll get more details on the upcoming new awards. And then in October, we'll be holding an office hour to answer technical and clinical questions and have some FAQs available as this new award settles in. And we're very excited to learn from your experiences and figure out ways in which we can support you to achieve this new award designation. If you could go to the next slide. Before handing the closing remarks over to Heidi, I just want to again recognize the team from all of our 4 host organizations, the American Heart Association, the Texas Department of State Health Services, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership, who all have helped make this virtual series possible. Thank you all for all your hard work. And we also want to thank all the participants who bring it to life. Now I want to turn it over to Heidi McPherson, the Senior Community Director of Healthcare Systems and Community Impact, to close us up today. And alongside so many of you, Heidi has been an integral part of the efforts in the Texas Hypertension Control Summit and the statewide movement. Heidi, I'll turn it over to you. Thank you.
Thank you so much, Allison. Good afternoon, everyone. I just want to start by expressing my appreciation to everybody who's contributed, to each of the speakers who shared their expertise today. We really appreciate it. And to each of you for joining in and being a part of the conversation, and for all the chat conversation as well. So if we move to the next slide, I just have a couple of things. First of all, we'd ask that you would take just a moment to fill out this evaluation form and provide some feedback and input for us. Again, like Allison said at the start of this event, that helps us shape the future sessions. And we've got several more to go. And then also just recap, Allison's given us this opportunity to join the national event on September 30th, and a recap of what those new awards are. As we look towards our state goal here in Texas of improving hypertension control to above 70%, and the conversations that are happening in the regional collaboratives around the state, what are some of those pieces that we can take back to our regional collaborative conversations and each of the clinical systems that are engaged? What can we do between now and December 31st as far as those systems changes to begin moving the needle even a little bit further towards our collective goal? So ask you to take some time to think about that. And for those of you who aren't already connected to one of the regional collaboratives around Texas, you're welcome to contact me. My information is right there on the screen, and I will connect you to the respective leaders of those collaboratives. So please do join if you're not already connected. And then let's go to the next slide, just the final point. We ask, we ask and welcome you to join for the remaining events. The next event in this series is October 20th. We'll focus on the Act Rapidly component and resources there. And then November 5th, we're going to talk more about partnering with patients. And on the 17th, we'll have our 17th of November, excuse me, we'll have our virtual poster session. So we welcome abstracts. The submission deadline for the abstracts for the poster session is coming up as well. And then we'll celebrate the progress that we've had over the past year or so with the awards session from the data that was just submitted at the beginning of this month for the 2019 cycle. So I know we're going to be recognizing many of you. Thank you all again for your time, for your contributions, and we'll see you on October 20th. Take care.